Welcome back to Invest Africa. Still with me, my guest, Dr. Marlon McKay, health practitioner here in Johannesburg. And now we're also joined by Dr. Ouma Oluga. He is the secretary to the Doctors Union based in Nairobi. Gentlemen, welcome. Dr. Marlon, let's come back to the money trail. Are we getting a sense that communicable diseases have not fallen off the radar when it comes to fiscal priorities in South Africa and maybe even the broader continent?
I think all countries, and especially in Africa, we acknowledge that if we are not investing money and spending money on communicable diseases, we are not going to win any battle whatsoever. We are lagging behind, and the priority has to be fiscal injection into making sure. Okay? And so where does the money come from? I think firstly, countries need to spend more money themselves on the healthcare budget.
Right.
I think if you look at some of the success stories, like in Ghana, for instance, where they have where delivery care services are free, so more women came forward for antenatal care, and the maternal mortality rate reduced substantially. Okay, so it can work two ways. I think we need to start moving away. Money from donors is going to be reducing. Right. We're not going to get sufficient money there. And so we need to look at our own healthcare budget system, investing more money, but also looking on the ground at community level in terms of assisting patients and maybe reducing fee for services, direct cash payments, and allowing more people to come forward to access the services free of charge. And for me, it will make a big difference in terms of reducing those numbers.
Dr. Ouma, I know we've just brought you into the conversation, but perhaps you can just give us a sense of how the Kenyan government has approached the healthcare budget and funding, in particular for communicable diseases. Are we finding that this is a priority in East Africa and in particular for Kenya?
I think the situation is almost the same as what the gentleman, my colleague, doctor in Johannesburg, has talked about. The Kenyan government, unfortunately, is yet to prioritize healthcare as a whole, not just for communicable diseases. I believe this is a problem for the whole of Africa. Looking at the Abuja Declaration, actually in 2001, only 11 countries have actually moved towards getting to 15% funding for healthcare. And Kenya, unfortunately, is one of those countries that have been declining. This year, the Kenyan government allocated 2.8% of their national budget. Out of a budget of 2.1 trillion, the Kenyan government allocated only 59.2 billion, which translates to about 2.8% of the national budget. And that puts us in a problem because even though we have not yet sorted out the problem of communicable diseases, we still have malaria as the leading cause of death in the country. We have issues of HIV. About 1.6 million Kenyans are still infected, with about 100,000 new infections every single year. So we have not yet optimized control and even treatment for communicable diseases. We have diarrheal diseases. Recently we had cholera outbreaks. And then now we are still even having non-communicable diseases also rising, but we have not yet controlled our communicable diseases. We're still having malaria. We are yet to get to zero with HIV infections. We have not yet, there's been a lot of progress in child maternal transmission, but still we are not yet there. So we are still in a bad fix. I think in the whole of Africa, East Africa isn't doing very well in healthcare funding. And I do want to agree that as much as we are talking, where will the money come from? I think we have the money. Our governments have the money. It's just that they have not yet prioritized the healthcare funding. If you are giving 2.8% of the national healthcare budget to healthcare, then there is absolutely no way we are going to get to control communicable disease. There's absolutely no way we are going to eradicate cholera outbreaks and malaria infections. So the money is there, and of course there are also a lot of donors coming into Africa. Kenya alone has about 26 billion Kenya shillings coming from donors. But again, that money I think may need to be prioritized. Unfortunately, policy in East Africa, or basically the whole of Africa, I think donors have a lot of say. So instead of governments telling donors where exactly the need is needed,
right.
Where the money is needed. Yes, they drive a lot of policy of what they want to do rather than what is important for the people. So I believe that is also an area of conversation where we could look at these 26 billion Kenya shillings. 26 billion Kenya shillings would translate roughly to about 25 million US dollars. So we have a lot of money that we can actually use to control some of these diseases, but we need the right policies, and government funding is still needed. The money is there. I believe that there's a lot of wastage in most governments, whether it's South Africa or Kenya or Uganda. So if we prioritize our healthcare and abide by the Abuja Declaration of 2001
right.
that advocated for 15% funding, then I believe we will be on the right track.
And I think what you've done, Dr. Ouma, is really opened up a very, very hot topic. And this, of course, donor demands trumping what the people need. But Dr. Marlin, let's come back to the urban-rural divide, because we also see a misalignment in terms of services when it comes to the medical and health space in this regard. How do we get that realignment back?
Yeah, I think we need to start focusing a lot more on the rural areas. But I think we've also done a lot, just in terms of building capacity, skills development, training, where even though we may not have qualified medical personnel in terms of doctors being accessible to everyone in rural areas, we've downskilled and upskilled nurses, for instance, who are primary care health practitioners, who are totally qualified in terms of management and even of the chronic diseases. And if you take the HIV model in South Africa alone, who have gone a far way in terms of assisting education, diagnosis, management of dispensing of ART medication. So that goes a long way. And if we are going to win this battle, we need to start focusing more on the rural areas. And that goes across the board. Vaccination, immunization,
right.
education, management of prevention of mother-to-child transmission. We are doing well, but a lot, as was mentioned, a lot can still be done in terms of focusing on those areas and reducing the numbers. The technology is there, the drugs are there, and we just need to make sure that, again, patients coming forward and resources are made available to everyone in rural areas.
So, Dr. Ouma, let me bring back this issue, because I think Dr. Marlin also touches on it, and this is affordability and accessibility of healthcare, in particular for the bottom of the pyramid and the larger part of the population. If you were to advise government from a policy perspective, how do we ensure that we increase accessibility and we increase the affordability of healthcare, in particularly around communicable diseases?
Health access is a big challenge in many of Africa, and I think again it falls into poor healthcare systems. We have seen even in West Africa, where there was the Ebola outbreak, it's simply a breakdown in the healthcare system. And I think the question of access and affordability cannot be isolated from a dysfunctional healthcare system. We have a situation where people do not have access, or they do not attain access, where you have the facilities are present at the rural facilities, but then sometimes the doctors or the nurses or the healthcare workers are not available. Or you have situations where people, the facilities for which are available, they can't afford it. This happens mostly in urban areas. For example, in Nairobi, where the nearest facility to you is a private facility, and therefore the ability to afford also comes in. So on one hand, I think the issue of access and affordability falls in universal health coverage. I think Africa must be very serious, and Kenya particularly must be very serious in terms of rallying the population, and the government must put up policies that actually will help people get access to insurance and also access to subsidies, sort of in a way to bring in universal health coverage. Here in Kenya, we have the National Health Insurance Fund that I think can be improved to cover more people. I think basically elsewhere, even in Africa, there must be some form of government insurance that I think can be improved to cover more people to have health insurance. On the other hand, also, I think the problem of also access also comes in with healthcare workers. Right. When you have doctors that are leaving Africa for other countries, Kenya included, then we must make sure that we retain those people. So we must handle our healthcare workers very well. We must make sure that we motivate and retain them. And then now, on the other hand, we drive a universal health coverage campaign If countries like Japan actually achieved universal health coverage in 1961, I believe Africa should have 50 years to have learned, you know, that we can actually do this. I think in Rwanda, they have some community health that is doing very well. I think such kind of initiatives should be multiplied.
Dr.
So
Ouma,
that we have...
thank you so much for those insights. We're unfortunately running out of time, and I just want to maybe give you an opportunity, Dr. Mullen, just to comment on some very important points that Dr. Ouma makes. The one is the feasibility of a national health insurance system in South Africa. Do you see that taking off? And also just the contentious issue of the private sector poaching healthcare workers from the public sector. Is that particular tension still prevalent in South Africa?
Obviously, the big issue in the context of South Africa with the NHI is funding. Where's the money going to come from? And for me, the other issue is, let's first fix what's broken. Work on what our issues are now and try and fix that. I don't think the word poaching is necessarily correct in terms of private versus. I think many doctors in the public sector get disillusioned with the public sector and the lack of resources and become extremely frustrated and therefore almost driven out of that environment and into the private sectors. So we need to equalize the forces there so that there is no, whether it is financial motivation or just in a sense of satisfaction, job satisfaction, that would literally force my colleagues out of the public health sector. We should make things conducive to an environment where we would want to stay in there, whether it's financially and job satisfaction, remain there and fix what's broken so that at the end of the day, as you were saying, everybody in South Africa can have equal access to good health care.
Some fantastic insights from my guest today. Unfortunately, that's where we have to leave it for this show. A very big thank you to Dr. Ouma Oluga. He's the secretary at the Doctors Union in Nairobi. And of course, Dr. Marlon McKay, health practitioner in Johannesburg. For you at home, if you want to be a part of these conversations, all you need to do is drop us a tweet. The hashtag is InvestAfrica, following us at CNBC Africa or myself at The Real Nosy. Let us know which sectors or hot topics in Africa you would like us to focus on. From myself and the Invest Africa team, it's goodbye.
Invest Africa, proudly brought to you by KPMG.